بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. السلام عليكم. Today we have VIVA Session number 23, genitourinary cases. Welcome to Easy Radiology Approach. Welcome to ERA, our YouTube channel. We have today one of our pioneers in the radiology field, Dr. Fathallah, consultant radiologist. He will join me in presenting the cases. Please, for all participants, please unmute yourself, except the can. It's good now. Okay.
I'm scrolling down, but I think it's scrolling very slowly.
Yeah.
So I can see that there is calcification around the thin hyperdensity along the wall of the urinary bladder.
Yes. Can I give you another series? Maybe
so
just a minute. Yeah.
Okay.
I think it's for a little bit slowly, but just a minute to upload the image.
Okay.
Okay, this is the stent as you described.
These are the plain images with in which I can appreciate that the liver appears normal. The bilateral kidneys also appears unremarkable.
Yes.
This stent is seen on left side. Urinary bladder shows slight hyperdensity along its anterolateral wall with mild thickening.
Yes.
And the digest stent is at its normal position.
Okay.
I cannot appreciate any abnormal perivesical thickening.
Yes. I think let's focus. Yeah, let's focus on this case because it's a simple case. But just to start with the simple case, we have a lower calcial renal stone on the left side. But to judge if there is any stones in the beside the stent, you should change the window and check if there is any stones or not. We don't have any stones along the applied WG stent. As you described, we have mural thickening, diffuse mural thickening in the urinary bladder.
Yes, there is mural thickening with subtle hyperdensity. I'm thinking that there is likely calcification of the bladder wall. With thickening.
Very good.
So the bladder wall calcification mostly occur. I will take the history if the patient has history of any schistosomiasis infection. Mostly bladder wall calcification occurs in those
very
cases.
Nice. Okay. Yes. Yes, very nice. Our top differential diagnosis in this case, schistosomiasis or bilharzial calcifications. Why it's bilharzial?
Sorry, I was not able to listen.
Why is it? Yeah. Why you told me that the most likely diagnosis bilharzial? Is there any other differential diagnosis for these calcifications?
Chronic cystitis can also cause such type of calcification.
Yes.
And other possibility, likely chronic infection, as the patient also has the history of dysuria.
Yeah. Bilharzial, one of the top differential. The second differential
is chronic
all of
UTI.
these infections can cause chronic cystitis.
Yes.
Bilharzial and tuberculosis.
Tuberculosis
can cause calcifications, but these linear calcifications, this is with bilharzial. Tuberculosis can be irregular, nodular calcifications, and also most likely associated with ipsilateral renal calcifications and destruction. We don't have anything in the kidneys. By the way, the tuberculous calcifications most likely involves the upper ureters, the kidneys. The bilharzial most likely involves the lower ureters and urinary bladder. Okay. We started by this simple case findings. This patient was complaining of dysuria and hematuria.
So can you please scroll it for me, as I'm not able to scroll it?
Okay, no problem. Okay, I will stop. Okay.
Yes. This is the MRI pelvis T2 images of a male patient who presented with pelvic pain.
Yeah.
So here I can appreciate that there is the bladder is showing wall thickness, mild smooth wall thickness.
Yes.
However, I cannot appreciate any mass or irregularity along the bladder wall. The prostate, yes, I can appreciate there is a subtle hyperdensity in the peripheral zone of the left prostate. I want to go at that area to confirm it. Yes, there is a hyperdense focus in the along the left lateral peripheral zone of the prostate. I want to see this on the diffuse restricted images to
Are you
rule
talking
out.
about this one? This
No,
area?
there was slightly, yes. Here. I
Yeah,
cannot see
it's
that.
well defined, well circumscribed, and also
Yes.
it is
Yes.
it's not present in the peripheral zone. I think it's present in the transition zone. But
Yes,
ignore this one
at the
because
junction.
it's
Okay.
benign looking. It's well circumscribed.
Okay. Then
Maybe part of benign
transitional zone.
prostatic hyperplasia. Okay.
So the bowel loops, pelvic bowel loops appears normal. I want to the bladder. Yes, there is an irregularity along the interior wall of the urinary bladder. I want to see it on the other images as sagittal, if available, sagittal T2 available. So these are the sagittal T2 images in which I can appreciate that there is thickening of the bladder wall more along the anterosuperior aspect. So I'm thinking about any urachal, likely it could be urachal cyst, infected cyst, but I cannot see any. I want to see the post-contrast images also, as well as the diffuse restricted images.
Okay. Before the post-contrast, can I give you the diffusion? Maybe helpful for you.
So on the diffuse restricted images, this area in the bladder wall is showing no diffuse restriction. However, I can appreciate
which
abnormal.
Which part of the urinary bladder?
Interiorly, where I mentioned the thickening and
anteriorly,
anterosuperior aspect of the urinary bladder.
Here?
No, it was superiorly. Yes, this area. Yeah, here.
Okay. Let's return back to the. Let's see the coronal T2. Is there anything in the dome of the urinary bladder or not? I think I don't have any masses in the dome or superior wall of the urinary bladder.
Okay. So then I will rule out the cause of this urinary bladder thickening. I will look the prostate and the base of the bladder to rule out any evidence of chronic obstruction.
Okay. This series is post-contrast series. Can you see any changes?
Okay. Yes, I can see there is thickening along the posterior wall.
Yes, perfect.
Left posterior wall of the bladder.
Yes, perfect. This area.
Yes, this correct? Area. Yes.
Let's return back to our axial.
Yes. Okay.
Axial T2. Okay, in this area. Okay, so we have something here abnormal.
Yes, here. Yes.
Is that correct? How can we describe this lesion?
This is there is thickening and there is evidence. So this thickening is extending into the urinary bladder wall. In the lumen of the urinary bladder.
Okay. Can I help you if we need to describe any masses or any lesions along the urinary bladder? We should describe first. Is it the number? Is it single or multiple? The site and size, the depths, and invasion of the surroundings. Those are the 4 points that we need to describe any urinary bladder mass. This mass is small polypoid mass. Okay.
Yes.
As you described, it is located along the posterior wall or trigone. Left side of the trigone of the urinary bladder. Okay, it's very close to the ureteric orifice. as you can see here, but it's not obstructing the ureters. It doesn't invade the ureteric orifice. Yes, and it displays iso-intense signal in T2 with image, as you can see. And in the diffusion here, is there any restricted diffusion or not?
Yes, it is showing restricted diffusion. I will confirm it on the DC.
It's restricted diffusion. But I want to add something here also. This area of restriction, underlying this area, we have hypointense area here. So is it invading the muscle or not? We need to describe the depth of the lesion.
Yes.
This is the muscle layer, dark signal. This is a normal dark signal of the muscle layer of the detrusor muscle of the urinary bladder. So it is preserving its dark signal. So no invasion. Okay, according to the T2 signal, if we are preserving the dark signal in T2 with image of the muscle, so we don't have any evidence of muscular invasion. Okay. Also, in the diffusion, we have for a little bit small area of non-restricted diffusion deep to the lesion, so we don't have any muscle invasion. For me, if I see something like this, I may suspect maybe ureteric jet, okay, from the ureters. But please check the other sequences, check the post-contrast, you will find it is enhancing. So we have small polypoid mass lesion, and according to the staging of urinary bladder, we should differentiate between T1 and T2 staging. T1, it's mucosal or submucosal mass, not invading the muscle layer. T2, it's invading the muscle layer. So this one is T1. And if we need to report this one, we should also, if we need to be at a higher level of reporting, we should report this one as VIRATS 1. VIRATS means physical imaging reporting and data system. This is categorized as score 1 because it's not invading the muscles and it's less than 1 centimeter. Okay. Okay, this one is proved to be small urinary bladder carcinoma. Okay, transition cell carcinoma. Okay, and if you have any case of transition cell carcinoma or bladder carcinoma, you should comment on the depths as we described. No perivascular extensions, no ureteric orifice invasion, no lymph nodes, no lymph node enlargement along the internal iliac or external iliac or common iliac. Also, if you have any bladder masses, you should take at least coronal T2 to cover the both kidneys, searching for any multifocal urothelial bladder cancers. Okay? Okay. Thank you so much, candidate number 1. It's a tough case, but you did very well. Thank you so much.
Thank you, sir.
Can we shift to next candidate, please? Candidate number 2. Wa alaikum assalam wa rahmatullahi. How are you?
I'm fine, alhamdulillah. How are you?
Alhamdulillah. Okay. Let's review the case. Okay, this case, can you please, if you want me to scroll, okay, if you want to scroll by yourself, you can send for me request for remote control.
I will try to scroll, but if it's heavy or lagging.
Okay, okay, no problem. I will help you. Try to scroll. This patient, presented with fever of unknown origin.
Okay. Okay, this is axial cut CT abdomen with contrast, portovenous phase. Just I will scroll and then I will comment. I can appreciate this is a male patient, urinary bladder appearing normal, prostate appearing normal. Just I will go up and then to look for both kidneys and also the intestine. No evidence of intestinal obstruction. Just I wanted to have a look and then I will comment. Okay, both a lung window appear, no evidence of effusion. When I'm going down to the liver appearing normal, the spleen also appearing normal. I can appreciate that there is evidence of mass lesion noted within the pancreas. It shows contrast enhancement. I'm not sure if it's from the pancreas or it's behind the pancreas.
Okay.
I will come back to it. And also there is evidence of abnormal hypodensity noted within the right kidney.
Yes. Perfect.
Okay. I'm trying to look for the in the kidney. Both kidneys appear in good contrast. They show well enhanced, apart from this hypo-enhanced region. If this patient coming with fever, it could be pyelonephritis in the right kidney, or it could be with this mass. I wanted to correlate no evidence of fat stranding surrounding.
Are you sure?
I'm just trying, maybe, yes, in the right kidney, surrounding the right kidney, there's
Yes. These
stranding.
fat planes
Yes.
on the right side, it's totally
Yes.
different than
Yes.
the left side.
Yes.
So we
There
have
is
smudging of the
yes.
perinephric fat. Yes.
Yeah, I wanted to look also for the renal vein appearing opacified,
Very nice. Very nice.
and also
Okay.
the renal artery. So
Yes.
it could be infection by pyelonephritis in the right kidney associated with fat stranding, and just want to exactly localize what about this.
Yes. What
Uh,
is this?
Yes, I'm trying to see. I think that's in the coronal view. Can I look for it? Because it appeared to be behind the pancreas. I wanted to look for the adrenals also to exclude any lesions.
Can you please
appear
continue
normal.
to the lower slices
Okay.
to see the continuation of the mass?
Okay, it appear to extend it. I lost it. Just 1 second. I will try. Yes, it appear to extend it down to the pelvis. Again, down, down. Okay, it appears to, it ends here. I will just go down more. Sorry. It's a blinded end, or it's a very large.
Okay, can you ignore this mass for a little bit? We will see this one in the coronal plane.
Yes,
can we
I
focus
want
again on the mass on the right kidney? You told me that this one may be infectious disease
Yes.
because we have a smudging of the fat planes and we have the clinical presentation of fever.
Yes.
Okay, I totally agree. But I need to ask you, is this lesion start to localize and liquefy or not?
Yes, yes.
Start to localize. Yes, it's
So
acute perinephritis, but it start to
it could
localize.
be renal abscess. It could be.
It's not yet renal abscess, but it's going to form renal abscess. So we have this stage between acute pyelonephritis and renal abscess. What is the most accurate term for this one?
Could be this is a phlegmon, still not.
It's called Lobar nephronia.
Okay.
Yeah, Lobar nephronia. It's stage between acute pyelonephritis and renal abscess. Okay.
Okay.
I totally agree with this idea. Okay, but I need to ask you, what's more?
Can I have a look again for all the cuts?
Yes.
Okay. Standing. Just I want to go down in the pelvis.
Is there any value to see the lower cuts and urinary bladder and the rest of the urinary tract?
I just wanted to exclude any abnormality. If there is any evidence of stones, if there is any evidence of masses in the scrotum, if there is any abnormality in the scrotum.
What is the most common organism in acute perinephritis?
E. coli or
E. coli, yes, correct. Perfect. Okay. What are the sources? What are the infectious sources for this case? if we have a case of acute pyonephritis.
Yes, it could be
Maybe,
hematogenous, but it
yes,
could,
very
yes,
nice. Maybe hematogenous spread, maybe ascending infection.
yes.
And this one
From
is
the
more
urinary
common,
bladder.
ascending infection from the urinary bladder, cystitis, or
Yes.
something else. Do we have any other infectious process involving the urinary tract?
I am trying to locate.
Yeah,
from
try
the
and
beginning,
focus.
the urethra.
Ignore the urinary bladder and urethra. Okay.
Okay, I
Let's
will
go
try
upward.
to
Yeah.
look for the ureters and
Can you check the ureters, please? Yes.
yes, I will try to look for the ureters.
The upper ureters.
It's not responding. Yes, start to respond. Okay. Just I am trying to look at the right. Yes, the right upper ureter appear to be also dilated and fat surrounding.
Okay, agree.
Sudden, and after this, it's coming back to its normal caliber.
Okay, is there any mural thickening or enhancement
Yes,
in
yes,
the renal pelvis or right ureter as compared to the left side? Stop
yes,
here, please. Yes.
yes.
If you
This one,
concentrate, can you give me the hand, please? Yeah. If
yes,
we concentrate in this scan, you will find here there is mural thickening in the renal pelvis and upper ureters as compared to the left side.
yes.
So we have some sort of
Infection, yes,
acute pyelitis.
yes,
This one is acute pyelitis.
yes,
This one,
enhancement of the wall.
this one can be the source of infection or can be secondary to the infectious process in the renal
Kidney.
cortex. Okay,
Yes.
so this one may be the cause, maybe the complications. Okay, so but we need to mention this one. We have acute pyelitis in the right renal pelvis and right upper ureter. Okay, regarding this mass, to close this case, if we see the coronal plane, the mass besides the urinary bladder, it's not a mass, it's a pseudomass. Look for this one.
Yes.
It's non-opacified bowel loops, small bowel loops. Okay, it's continuous with the bowel loops, so it's not opacified. So yeah, it can mislead or can you can think it's like a mass, but it's not a mass. So this one is the infectious process, and also we need to mention something very important, that we don't have any extension to the perinephric space. This lesion or this infection localized at the renal cortex, stretching the cortex of the kidney, but it doesn't extend to the perinephric space or pararenal space. Okay, we did really follow up for this case, and let's see. Let's see. Okay, let's see. This one is after I think 1 week or less than 1 week after conservative treatment, and look for this one. Significant regression. Yeah, significant regression of the lesion and significant regression of the smudging of the fat planes. So this is a favorable conservative treatment. Okay, thank you so much. Can you stay with me, please? We can go to the next case.
Okay.
Okay. I will scroll for you.
Okay.
To be more easier. Okay. Hematuria.
Yes, in this axial cut T2, I can appreciate that there is of the pelvis. I can appreciate that there is evidence of abnormal hypointense signal noted in the base of the urinary bladder. It appears to relate it in the trigon at the left, maybe at the left vesicular junction.
Yes. Very close to the ureteric orifice. Yes, very nice.
Yes.
Okay. Is it obstructing or not?
No, there is no
no significant obstruction.
No significant obstruction, and it appears to be hypointense. And differential diagnosis for this could be blood. It could be blood clot, or it could be a mass in the urinary bladder. I wanted to look for the post contrast. And
but this outline, serrate outline, it's not. It doesn't look like hematoma really, but it's very suspicious. If you are suspecting hematoma, what should you do to confirm?
I would look for T1 also.
Yes, very nice. Okay.
Just because it's dependent only, so and the patient coming with hematuria, so I'm just putting it as a differential diagnosis.
Okay.
So I would look for here. I want to look for the post contrast if it show any post contrast enhancement. So it would be
This is a T1.
It appears to be hyper intense. Really,
it's not so much hyper intense. Really, it's iso intense.
okay.
But if we need to confirm
post contrast and the diffusion.
Post contrast, is it enhancing or not? If it is hematoma,
yes, hematoma will not enhance.
Will not enhance. Yes. Another criteria for hematoma, please take prone position. If it is mobile,
yes,
for sure
it would be hematoma.
Okay?
Yes.
Don't forget this point. Okay, but this one it's not mobile. Really, it is arising from the left posterolateral aspect of the urinary bladder, very close to the ureteric orifice, and this is a polypoid mass, exophytic polypoid mass.
Yes.
As we described before, we need is it single? Yes, it's single.
Yes, we
Size
have
and size we mentioned
for
before.
the ureters and for
give me an idea for the depths.
Idea for what?
Give me an idea for the depths.
It's not too much deep. I think it's not infiltrating the bladder.
It's not infiltrating for sure. It's not infiltrating.
Yes.
Look for the urinary bladder. This is the muscular layer.
Yes, the muscular
very smooth, very thin.
Well marginated.
It's not thickened. It's preserving the dark signal in T2 with image, so it is not invading.
Yes.
The urinary bladder muscle. Okay. By the way, can you give me an idea about the normal dimensions of the urinary bladder wall? Because it's
2 to 3 mm, not more than 3 mm.
It's from 2 to 8 millimeter. Okay, according to the urinary bladder distension. Okay. And by the way, the mucosa and submucosa, it is not well demarcated in the T2 with image. In the T2 with image, only we can see the dark, low signal intensity of the muscle. Okay. Okay. Thank you so much. So this one is stage 1 or 2?
Stage 1.
Stage 1. Stage 1 is really, it's very important to differentiate between stage 1 and 2, because stage 1 it's superficial tumor, and it's suitable for transurethral resection for bladder tumors. Okay, transurethral resection bladder tumor. So this one is very suitable. Okay. Thank you so much. Kent number 2. Kent number 3. Kent number 3.
Assalamu alaikum, sir.
Wa alaikum assalam. How are you?
Alhamdulillah, sir.
Alhamdulillah. Okay.
Should I ask for control?
Yeah. Okay, no problem. Okay, go ahead.
Okay. Yes, I've asked for control.
Yes.
Should I start, sir?
Yes. Go ahead.
Okay.
The patient, presented with hematuria.
Okay. I am presented with MRI of a male patient. And I will these are the T2 weighted image. I'll first scroll through the images, and then I'll start describing my findings. So this patient presented with dysuria. I am looking at the urinary bladder of this patient. The the urinary bladder shows irregular wall thickening, and I can appreciate an area of polypoidal wall thickening along the right lateral wall. There are some it seems to be in close proximity to the vesico-ureteric junction. However, there is no dilatation of the right ureter.
Very nice.
can appreciate that the T2 hypointense muscular wall of the urinary bladder is preserved throughout the preserved throughout the urinary bladder. Although on few images, I can appreciate there is the T2 hyperintense wall is the T2 hyperintense wall is interrupted, and there is some fat stranding in the perivesical fat. I can also appreciate there are so there's some layering of altered signals in the posterior aspect of the urinary bladder, although that might be due to motion artifact. I would confirm it on on other images. I can see that there's some layering in the seminal vesicles.
Okay.
Uh,
Which sequence do you want to see to help you more?
Yeah, I would want to have a look at the T1 and the post-contrast images if available.
Okay.
Okay, so this is the okay. This is the T1 weighted image. Okay, I can again see T1 hyperintense area within the seminal vesicles, which might again the wall irregularity is again appreciated in the urinary bladder. Can I have a look at the post-contrast images as well?
Just a minute. Can you give me the hand? I will give you just a minute. Just a minute.
Yes.
Can you please check the diffusion first? Okay.
Okay. Okay, the area, the T1 hyperintense area within the seminal vesicles also shows diffusion restriction. There's also so these are the diffusion restriction images.
You can go more. Yeah, you can scroll more. Yeah, go down. Yeah. Okay.
Okay. So there is a diffusion restriction. There's a diffusion restriction within the seminal vesicle lesion. Also within the bladder wall,
Yes.
I can appreciate some diffusion restriction. So based on these images, my first suspicion is of bladder carcinoma, which is invading the wall and also invading the seminal vesicles.
Are you sure regarding the invasion of seminal vesicles?
No, I'm not sure about the seminal vesicle.
Okay.
No,
But it's
because
invading
it's not restricting. Yes.
Okay. Okay. So what's your next step?
My next step would be I would want to have a look at the post-contrast images, and this is a T3B mass of the bladder. I would want to have a cystoscopic biopsy of this lesion and a contrast-enhanced CT scan for of chest, abdomen, and pelvis for staging of the patient.
Okay. Regarding this cystic lesion, what do you think?
So it's hyper on T1, so it might be a lipoma or it might be a hemorrhage, or I can confirm it on fat saturated T1 image or fat saturated T2 image. If it would be hyper intense on those images, then it would be a
let's okay. Thank you so much. I think you did very well, but I need to just modify some points. Regarding this mass, as you described, we have for a little bit mild non-uniform circumferential mural thickening of the urinary bladder, but we have a mass, and this mass, it is like polypoid mass, but with a broad base. So it's not pedunculated, it's non-pedunculated polypoid mass involving the right posterolateral aspect or wall of the urinary bladder, but it extends to the dome of the urinary bladder. Which plane do you prefer if you have something like this? If we have a mass, tell me.
A sagittal image?
Sagittal or coronal. Okay.
Or coronal.
Yes, coronal is very important. If we have a mass in the right lateral or left lateral wall, axial plane, it's very important to have axial plane and axial diffusion, okay, to assess the mass. But if we have a mass beside the dome or in the dome of the urinary bladder, the best plane to judge or to make a precise localization and invasion of the muscle is a coronal and sagittal plane. Okay, so if you have something like this, please ask me to see the coronal plane. Look for the coronal. It's very easy. It's invading or it extends along the dome of the urinary bladder. And as you said, I don't have clear demarcation of the dark T2 signal of the muscle layer. Do you agree with me?
Yes.
Yes. So it's likely invading the muscle layer. So this one is considered as stage 2. But we don't have any perivesical extension. Just it is invading the muscle layer of the urinary bladder. And if we have coronal diffusion, look for this one. Look for the mass here. This is a mass. We are doing the diffusion not only to see is it restricted or not. It will help you in determining the depth of the lesion. Okay, so this is a mass, and this one going inside the wall. Look for the one. Look for this area. It's extending inside, intramural, invading the muscle layer. So it confirms again T2 staging of the mass. Regarding this one, this cyst is just superior, midline, just superior to the prostate between the both seminal vesicles. This one, we have two types of midline cyst, either prostatic ureterocele cyst and Mullerian duct cyst. Most likely, according to this location, Mullerian duct cyst. But we have two differential signals. High T2, high T1 signal may be proteinaceous content, may be hemorrhagic content. Okay, but really, I present this case to describe or to focus on the urinary bladder mass. Okay, and also we don't have any pathologically enlarged lymph nodes. And as you told me before, the best next step is to perform cystoscopy and biopsy. Okay. Okay. Let's go to this next case. Okay. This case really it was a little bit strange, and the patient presented with dysuria, and we did ultrasound for the patient, and the ultrasound report revealed urinary bladder stone. Okay.
Urinary bladder stone.
And really, yes, urinary bladder stone. And the physician called me that he did the cystoscopy to remove the stone, but he didn't find any stones. He found urinary bladder mass, and his concern is it arising from the uterine cervix and invading the bladder, or is it urinary bladder mass itself? Really, he didn't know. Can you help me?
Okay, sir. So I'm provided with the CT scan, this MRI T2 weighted image of a patient who has a suspected mass in the urinary bladder. I'll first scroll through the images. So there's an irregularity in the posterior wall of the urinary bladder, which appears to be on these images. It appears to be an extrinsic mass arising from the So can I have the sagittal T2 weighted image?
Yes, correct. Perfect. This is the most perfect point. Yeah, sagittal. Okay, go ahead.
Okay. So I'm trying to scroll. Okay. So the uterus and cervix are well away from the lesion, and I can see that there is the mass appears to be arising from the posterior wall of the urinary bladder.
Yes, perfect.
Yes.
So it's
And
not, it's not from outside the urinary bladder.
Yes.
It's not vaginal mass. It's not uterine cervix mass. It's present at the trigone or posterior wall of the posterior wall of the urinary bladder. Is that correct?
Yes.
Okay. Can we characterize more the mass?
So the mass has central T2 hypointensity in it.
Fantastic. Yes.
So this could represent This could represent a hematoma.
But really, he didn't find any hematoma in the urinary bladder.
Okay. I can see that the wall of the T2 hypointense bladder muscular layer is not continuous at the site. I can I have a look at the post contrast T1 and post contrast images of the patient?
Okay. Just a minute. I will make here is axial T2. Okay, and this is the post contrast. Okay. You can scroll and show me.
Okay. I'm trying to scroll. It's not moving.
For you, just a minute. Okay. Okay.
Yes.
This is a mess. Okay. Is it enhancing?
Yes. No, the mass it's not enhancing.
Yes,
there is
the mass is not enhancing.
I can see
this is axial. Sorry, this is the sagittal T2. So sorry, sagittal T1 set post contrast, and this is the mass. Is it enhancing?
Yes. The mass is not enhancing.
It's not enhancing. This is a bladder cluster, and this is gravitating contrast, and this is gas, floating gas, because of the inserted cluster. Okay, let's focus again on the mass. What should you do? It's dilemma.
Now we've already had the cystoscopy done.
Cystoscopy was done, and he didn't find anything apart from a mass arising from the trigone of the urinary bladder.
So can we have a look at the DWI to see if it's restricting?
It's not restricted.
Okay.
To save your time. Yes.
Okay. I can. So what if we can we have a cystoscopic biopsy removal of this mass?
Okay, I'm talking about the radiology.
Can we have
tools.
a CT urogram?
CT, okay. I will give you the CT. Maybe helpful. Okay, just a minute. Okay, this is the CT for the same patient. Okay.
Yes.
Yeah, you can scroll.
Okay. I'll.
You have only 2 minutes to give me an idea.
Okay.
I'm sorry to make a pressure.
Okay. So this lesion is calcified on
Very nice.
plain scan.
Perfect.
So yes. So it might be a a calculus which is
We have no
which is
calculus in
adherent to.
cystoscopy.
Okay.
All the
So
time,
it
I will remind you, we don't have any stones in the
so
on
it
this.
can be a calcified mass.
Okay, can be calcified mass. Okay, agree.
I cannot see any. I'm trying to see if there's any. There's no dilatation of the kidneys. There's no hydronephroureter.
Okay, can you check the right kidney? I know
Okay.
it's difficult, but can you check, please? I want to tell you that I did what you did exactly in this case. It was a dilemma. Okay.
So this is I can see two ureters arising from the.
Yes, perfect. Perfect.
Yes. So this might
what's
be
your
a
diagnosis?
ureterocele. So this is a ureterocele, and there's a calculus within
You are
the
amazing.
ureterocele.
You are amazing. Give me the hand. Okay. Really, when I saw this case, just a minute. Give me the hand, please.
Okay.
Give me the hand. Okay.
Yes.
Okay. This mass, when I saw this mass, it looks like a calcified mass arising from the urinary bladder, but it's very strange, dark signal. And also, if I start to trace the ureter, the right ureter, this is the right ureter, and the stone ends in the right ureter. So I called the phone again, and I talked with the clinician. I told him the stone it's present inside the intramural portion of the right ureter. He told me no, the right ureter is free. So again, it's a dilemma for me. What is this one? So I did CT scan for this case, and I found, as you described, I found duplex kidney and duplication of the right ureter, as you see here. So if you find here, this is the upper moiety.
Yeah.
This is the right ureter, and another ureter from the lower moiety. So we have here two ureters. This is sorry. If you can see here, this is one of the right ureters, and this is another one. So I thought this one may be duplex kidney with complete duplication of the ureter, and this is stone in one of the both ureters on top of ureterocele. So we did really CT, post-contrast urography for the same patient, and as you can see here, we have complete duplication of the right ureter, and as you can see here, we have ureterocele with a stone. So it's very clear now to have duplex right kidney. Also, if we can see, look for these two ureters. We have complete duplication of the two ureters with a stone. Urinary frequency in urination. Okay, this patient is 10 years old. Okay, you can scroll if you want. Can you send for me request for remote control?
All right. Yes, I've requested.
Okay, go ahead.
All right. So I'm presented with CT scan axial sections, post-contrast images. And as I'm scrolling through the images, I can see that there is hydronephrosis seen in the right kidney. There is also dilatation of the right ureter. There is also mucosal hyperenhancement of the dilated ureter, and also of some of the hypodensities in the kidney. Now I'm tracing the right ureter. So as I'm going down, I can see it is dilated with peripherally enhancing mucosa. Now I'm tracing the ureter downwards. All right. So as I'm going down, I can see bladder is also distended, and there is an outpouching arising from the diverticulum on the right side, in which this ureter on the right side is opened.
Yes.
I want to see the cornel sections if available.
Okay. Before coronal section, can you give me more data or more findings? What?
Yeah, the
your suggestion?
urinary bladder shows thickened wall. There is trabeculated and thickening of the wall of the urinary bladder. However, I'm looking for any hyperdense calculus, which I'm unable to see. Um, I want to see the status of right kidney also. This enhancement in the left ureter is suggestive of undergoing infection, likely pyelitis.
Yes.
I'm now going to see the status of right kidney also. The right ureter is not dilated. The right kidney appears to have okay, so it is showing excretion of contrast in the ureter. And in the right kidney, I can see that there is multiple patchy areas of hypodensities along with hydronephrosis, giving the striated nephrogram, which could be suggestive of pyelonephritis and any collections or renal abscess formation. However, there is no
where is the renal abscess? Can you localize where is the renal abscess?
As I was going down, maybe here, I'm not sure.
You
I
have
would like
any
to
renal
see
abscess?
the cornel sections also. I think this is hydronephrosis all with pyelonephrosis levels. Some levels are also seen.
Yeah, but we have a renal abscess. Can you localize this renal abscess?
Okay. It is seen here.
Yes, 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 you are right. We have like multicystic lesion, cortical based, along the upper pool or located at the upper pool of the right kidney. Yes.
However, there is no thickening of Girota's fascia or perinephric fat stranding seen.
Okay. Can you please give me an idea about the renal cortex? Is it smooth or not smooth?
Renal cortex is not smooth. There is an evidence of renal cortical scarring noted.
Yes, perfect.
Yeah.
Why we have renal cortical scarring?
Because of the recurrent infections.
Yeah, perfect. Recurrent ascending infection. Okay. Why we have recurrent ascending infection?
Because I can see that there is ectopic insertion of the ureter and there is dilatation of the ureter, which is likely the cause of recurrent infections.
Okay, agree. Partially agree. Because we have, can you please scroll down?
Yeah.
To see the urinary bladder again. Can we focus again on this saccular outpouching arising from the urinary
there was
bladder?
a saccular outpouching. This is the ureter. I'm pointing it. This is the ureter and it is seen to be open in this outpouching, and this outpouching is seen to be communication with the urinary bladder.
Yeah, okay.
It could be a suggestive of Hutch diverticulum, but that are bilateral.
Very nice. Very nice. It's Hutch diverticulum. It's congenital diverticulum. Yeah.
Yes.
Why it's congenital?
And is also associated, they are more prominent.
I think you did very, very well. This is the saccular outpouches. Saccular outpouch arising from the right posterolateral wall of the urinary bladder with wide neck, and its wall is continuous with the diverticulum, so it's true diverticulum, full layers of the diverticulum similar to the urinary bladder, and this one is in patient 10 years old, so it's not logic to have acquired diverticulum secondary to outlet obstruction. So this is congenital diverticulum, And also, this is the exact typical location for the congenital diverticulum.
Yeah, it is seen at the vesico-ureteric junction.
Okay, let's see the 5 minutes. This one is a delayed. Let's see the delayed. I think we presented this case before. I'm not sure really.
No.
But if we see this ureter, this is the right ureter, and the right ureter inserted in this outpouch. Okay,
Yeah.
this is a typical, yes, this is a typical exact location. So we have disruption of the normal oblique course of the right ureter. So we have recurrent vesico-ureteric reflux causing pyelitis and recurrent ascending infection, acute pyelonephritis in the right kidney, and with renal abscess. And we have cord carina scarring because of recurrent previous old infection. Okay, thank you so much. Perfect. Candidate now. You are candidate number 4. Is that correct?
5.
5. So let's review some important tips here in our session. Bladder cancer can be classified according to the histological types into ureterocele or transitional cell carcinoma. This is the most important, the most common type. Squamous cell carcinoma, adenocarcinoma. Adenocarcinoma, it's more specific for ureteral carcinoma. The least common is small cell carcinoma. We have different morphological types of the bladder tumors. If we need to describe a bladder mass, we have main 3 types, either papillary pedunculated tumor. That means we have polypoid tumor or papillary tumor with endoluminal growth, with or without tumor stalk. We will describe this in the next slide. The stalk is hypotense in T2 and diffusion weight image, while it appears hyperintense or enhancing in the dynamic contrast enhancing sequence. May be invasive or not invasive. Also, we have papillary non-pedunculated tumor. This one is flat superficial tumors contained in the mucosa. Flat invasive carcinoma or sessile tumor. This one is intramural inside the wall of the urinary bladder. This is classified as flat invasive carcinoma or sessile tumor. As you can see here, those are the different morphological types of bladder cancer. Papillary pedunculated, as you can see here. Papillary non-pedunculated, as you can see here. It creeps along the mucosa. And the sessile or intramural gross or flat type of the bladder tumors. So if we need to describe, we should classify our description according to the shape of the tumor, as you can see here under one of these categories. This sign or this important point is called stalk. You can see here, this is the tumor itself, restricted diffusion. As you can see here in the ADC map, high in diffusion, low in ADC map, so it is restricted. But deep to the tumor, you can see this stalk, this one. Stalk is considered as a good sign, unlikely to have muscular invasion. So if you find this stalk, it is considered as a good sign, unlikely to have muscular invasion. But on the other hand, you can see a bladder tumor with a stalk with muscular invasion, but it's less common. So you should find or search for any stalk in any bladder tumor. It displays low signal on T2 weight image and shows non-restricted diffusion, as you can see here. But it shows intense contrast enhancement. Stalk is considered as a cellular tissue that attach or connects the bladder tumor to the urinary bladder wall. Those are some important literature you can review how to stage the bladder cancer. The most important one is a multi-parametric MRI. Multi-parametric, that means that we need to take T2 with image, diffusion with image, and dynamic contrast enhancements. Those sequences are important to stage bladder tumor, and as we described in our cases, if you have the mass in the right lateral or left lateral wall, or anterior wall, axial scan is very important. If you have the mass in the bladder dome or at the floor of the urinary bladder, coronal and sagittal is very important. Also, this article is so important. VIRATS, Vesical Imaging Reporting and Data System. This article also is so important. I have some slides. The next slides are from these articles. Besides these articles from the radiology assistants, we have some amazing diagrams. I want to see these diagrams with me. If you have this mass or how to localize the mass, you should know the anatomy of the urinary bladder. This is the dome, right and left walls. This is the posterior wall, and this is the trigone. The trigone is present between the both ureteric orifices down to the bladder level. As we described, it's very important to discriminate between T1 and T2 stage of the bladder tumor. T1 not invading the muscles, T2 is invading the muscle. This is TNM system, TNM staging classification. Okay, so T1 non-invasive, T2 is invasive to the muscle area. As you can see here in this diagram, T1 it's contained within the mucosa, T2 invading the muscle, T3 invading the serosa of the urinary bladder and going to the perivesical fat, T4 it is adherent to the adjacent structures outside the urinary bladder. Also, we need to focus on the different layers of the urinary bladder. As you can see here, the mucosa and submucosa, it is not visible on T2 with image, diffusion, and EDC map. We only see the mucosa and submucosa in the dynamic contrast enhancement. It will enhance. On the other hand, if we have any edema of the inner layer of the urinary bladder, it can display high signal on T2 with image and enhancing on the diffusion with image. This one is so important. We will discuss this one in details. So if we have a bladder tumor, for example, this is the urinary bladder wall, and this is the mass, and deep to the mass, if we have enhancing layer along the mucosa of the urinary bladder deep to the mass in the dynamic contrast enhancement, it is considered as a good sign, because this one is considered as inflammatory process deep to the mass. Hyperemia of the adjacent mucosa. So we don't have a gross invasion to the muscular layer. According to the classifications that we need to know, if you are subspecialized in the genitourinary cases, VIRATS, as we described, it's vesical imaging reporting in that system. Those scores can help you to determine, do we have muscular invasion or not? We have 5 scores. Score 1, 2, 3, 4, and 5. Simply, score 1, this mass, we have a clear dark signal line of the muscular layer, very clear, not disrupted. Also, we have in VIRAT 2, very clear muscular layer, very clear muscular layer. But what is the difference between those scores. Here, in the dynamic contrast enhancement, it is not invading the muscle layer. Here we have this line, as we described before, enhancing very thin line deep to the tumor. This can be hyperemia of the mucosa. In the diffusion with image, we have dark signal deep to the mass, dark signal core or cleft deep to the mass, not restricted diffusion. But the difference between VIRAT 1 and 2 is the size. VIRAT 1 less than 1 centimeter, VIRAT 2 larger than 1 centimeter. So it's the same, almost the same description. Both of these lesions are not invading the muscular layer, and we have here small cleft or small or very thin line deep to the mass or between the mass and the urinary bladder wall. And sometimes you have this thin enhancing layer of mucosa deep to the mass in the dynamic contrast enhancement. In VIRAT 3, we don't have these signs. We don't have any enhancing layer, as you can see here. We don't have any cleft or hypointense layer deep to the mass in the diffusion with image, as you can see here. So the mass is very close to the muscular layer. So this one is equivocal muscular invasion. As you can see here, it's very close to the muscular layer of the urinary bladder. VIRAT 4, the mass, clearly we can see the mass invading and disrupting the muscle layer, as you can see here in this case. Also, in the dynamic contrast enhancement, it's very clear to see the mass invading the muscle layer in the diffusion restricted diffusion tissue inside the wall of the urinary bladder. Here the mass is going outside into the perivesical space, so this mass is invading the serosa and bypassing the serosa into the perivesical path. So this one for sure, it invades the muscular layer VIRAT 5. So those are the scores to determine the muscular invasion of the mass. As you can see here, those are the different scores of VIRATs, as we described before. If you want to read it carefully, the same points that we discussed. I tried to collect the good signs in MRI imaging of bladder cancer. If the mass lesion is less than 1 centimeter, no clear disruption of the low T2 signal of the muscle layer, no abnormal focal thickening of the muscle layer. This one is very important. If you have a mass very close to the muscle layer and the muscle layer doesn't show any significant thickening, so it is considered as a good sign. Presence of low signal intensity of the stomach in the diffusion with image, as we described. Presence of early enhancement of the inner layer in between the mass and the urinary bladder wall. No metastatic lymphadenopathy along the internal iliac or common iliac lymph nodes. By the way, if we have any metastatic lesion in the common iliac lymph nodes, it's considered as a metastatic lesion, M1. Okay. Okay, let's go to the second part of our session. Dr. Fathallah will be with you in our second part. Thank you so much.
In the spleen, now we're moving to the kidneys. There is a ill-defined hypodense area is seen in the left kidney.
Okay. Go ahead.
I'm looking for the ureters. The ureters are not seen, I think, at the early phase. This is the corticomedullary phase. So now I'm looking for the urinary bladder. I'm going to inferiorly.
Actually, this is what is this phase, doctor?
This is this is 1 minute. I could go up. Yes.
Just focus on the renal system.
Okay. So I want to see this image are lagging. I want to. No, we cannot see kidney.
So what do you think about this kidney?
Yeah, this is the kidney. So in this kidney there is small hypodense areas are seen in the left kidney, with the similar hypodense areas are also noted in the spleen. So overall findings are suggestive of infective disease process, which is involving the left kidney as well as the spleen.
Just give me a second, okay? Let me show you another phase of this study. What do you think right now?
There is a patchy enhancement of the left kidney is noted. Rather,
only the left kidney or bilateral kidneys? Excellent. Go ahead.
So the changes are yes, the bilateral patchy enhancement is seen in the kidneys bilaterally, and there is some air loculi are also suspected.
No air loculi.
Okay, so I'm looking for any perinephric fat stranding. There is no perinephric fat stranding is seen.
Excellent. Okay. Excellent. You're doing very well, actually.
I could not see any stone formation. I could not see any collection in the source abscess, source formation in the source vessels.
Okay.
The findings are. I will also see the delayed images of this study.
Okay, that is the delayed image.
Delayed image as well coronal images.
Okay, I will give you the coronal image. This is the delayed image. Okay. You can see it scrolled. Okay.
Okay. Yes.
Okay. Nice. And this is the best phase of this study. Okay.
So on the coronal images, here I can see there is a patchy peripheral low density areas are seen. Non-enhancing area is seen in the kidneys bilaterally. These findings are suggestive of most likely infective disease process, which is involving the bilateral kidneys. This maybe
was the absence of the perinephric affection and the pelvic ureteric junction affection. You still give me the inflammatory process as the first possibility.
Yeah, there is no evidence of any perinephric changes, and the ureters are also not seen. This is so this could be related to, as you told, there is some chronic illness with the patient.
What you are suspecting from this illness?
This could be diabetes mellitus, or this could be some glomerulonephritis, vaginal granulomatosis, glomerulonephritis.
Okay.
Some connective tissue disorders. Just like SLE.
You actually stated very good differential diagnosis. But did you think about vascular compromise of these kidneys?
Yes,
you should tell me the renal artery and vein is patent, right? In the description.
Yes.
I went more back for the arterial phase.
The renal arteries appears normal on the left side. And
so what can give us this appearance?
This could be striated appearance of the kidneys bilaterally.
Again, if you please.
Striated nephrograms, striated appearance. So could be some thing like vascular abnormality, just like I want to see the vessels. Yes.
The vessels is patent for both sides, right?
Okay.
This is one. Okay.
Okay.
And this is the division of the arteries into the posterior and anterior branch, and this is the second one here.
Okay.
So it is less likely vasculitis. What else can cause us this one? You want to ask what is the medical illness she is taking?
Yes, the renal vein. Renal vein. I will also look for the renal vein.
Okay. Nice. It is patent.
Renal vein is patent. Yes. Other vein is also patent.
So, can this be appearance of multi-infection ischemia or chronic ischemia?
Yes, it could be chronic ischemia.
Then with patent vessel.
Yes.
So you are searching about underlying cause, right?
Yes.
Right. Let me give you the clear clinical data for this one. This is a known case of sickle cell disease on treatment.
Okay.
Okay.
So this could be sickle cell vasculitis, which is causing small this.
Exactly, small vessel or small.
Vessel
Exactly. When I stated this case, when I met this case, I was really surprised. What is this? Then I scroll down, as you said, is exactly. So this is multifocal, hypodense, non-enhancing, cortical, and medullary. It is involved actually the kidney, cortex, and medulla.
Yes.
Then I immediately scrolled to the bone window, like this one. I saw there is no evidence of any hemolytic disease. Yes, exactly. Then I contact the physician. What is this? He told me this is a known case of sickle cell on treatment.
Okay.
Okay, this is a little bit tough, I know.
Yes.
I know.
So there's a small emboli which is causing some narrowing and vasculitis.
Sickle cell vasculopathy. Yes, exactly. Can you stay?
First of all, I noticed there is low density is seen in the liver. This may represent hemochromatosis. Then inferiorly, I'm going to the kidneys. The right kidney appears normal in shape and size and contour. The left kidney appears enlarged, and there is multiple areas of altered MR signals are seen in the left kidney.
Okay.
Left renal vein is also appears expanded, and this is also extending into the left renal vein, which is causing the expansion of the left renal vein, and these masses there is some high signal areas are also seen in it. So these masses are suggestive of some neoplastic disease process, such as could be primary neoplastic mass lesion, or it could be due to some infiltrative disorder such as lymphoma. I will also see the coronal images, and I will see the T1 images and the coronal images.
Okay, can you give me the scroll? If you please for 1 second. Okay. This is the T1. You can scroll.
Yes. So on the T1 weighted images here, I can see the mass appears to be low signal, and it is extremely renal. In addition to it, I could also see there is small mass seen on the posterior aspect of the right lobe of the liver. Now we'll see the coronal images, coronal T2 weighted images, as well as the post-contrast images.
Nice. Okay, this is the coronal T2. You can scroll.
On the coronal T2 weighted images, here I can see the patchy heterogeneous irregular mass.
Yeah.
Yes.
Okay, this is the post-contrast coronal T1.
Okay. On the
post-contrast, what do you think?
I think this is the irregular enhancing mass lesion is noted which extending into the left renal vein. Left kidney also appears to be enlarged. I think this is my differentiation may include neoplastic disease process such as RCC, with other less likely differential may include lymphoma, or less likely metastatic deposits from previous known period, because there is some mass is also suspecting in the right lobe of the liver. So
okay, let me discuss with you this case. If I consider this one as a neoplastic process, okay, with infiltration and extension into the left renal vein, would be there is any enhancement of the vein if it is malignant thrombus?
Yeah, there must be enhancement.
Okay, but there is no enhancement, and we confirm it here like this one. Look, this is the post-contrast, by the way. Yes. What do you think about this lesion?
This could be hemangioma. because this is enhancing, and yes, these valve margins are well defined. So this could be hemangioma, which
you can see it right now.
Yes, yes.
Yes, we can see you.
It is scrolling, doctor.
Yes,
Yes.
yes,
But a little bit slow.
yes.
Okay. So this patient had an isolation of left renal vein thrombosis with the unilateral enlargement of the kidney. As you stated, there is still enhancement and cortical vein sign here. And this is isolated, or this is accidentally discovered small hemangioma.
Okay.
But you describe it very well. Unilateral enlargement of the kidney with the extension of low intensity signal inside the left renal vein that crossing the midline and joining the IVC, but not extending into the IVC. And the renal parenchyma is heterogeneously enhancing, mainly at the cortex, with preservation of the left ball enhancement. Here, you can see
Yeah.
this one.
Yes, yes.
I switch it to the coronal, you can see?
Yes, yes.
Okay. And this was accidentally discovered hepatic hemangioma. Okay?
Okay.
Sorry for the lagging for the internet. I don't know what is the problem, but you did very well in the
No problem,
description.
Dr. Fathallah. You are now going very well. I think the connection now is very good.
Dr. Muhammad.
Don't worry.
Okay,
don't worry.
Right. Can we switch to the next candidate?
Yeah. Next candidate.
I will share,
candidate number. Candidate number 8.
I will share one by one. Stop sharing.
Yes, hi doctor, how are you?
Oh, I'm fine. I'm doing fine, alhamdulillah.
Alhamdulillah.
Let me share one. Alhamdulillah. Let me share one case with you.
Yeah, sure, no problem.
You can see the scrolling?
Yes, I do see it.
Okay. You want to remote control this case?
Up to you, it's okay. You can scroll or we can ask for it. You can scroll or shall I ask? Or, okay.
I will scroll for you, okay?
All right, okay. Okay, this is a axial cuts of non-enhanced CTKUB, where I can see that there is a rounded hypodense area or mass-like lesion within the right kidney. The left ureter shows a elongated hyperdense structure. It could be a stent, a PUJ stent. There is, I can see also, I think, okay, there was a calcification also in the right side as well. On the left side, okay, sometimes it appeared splitted, but maybe it's just curving.
Okay. What else you want to do?
Okay, okay, I'd like to have a look at it at coronal, and I'd like to give contrast for this mass-like lesion which is seen on the right side.
Let me first go for window, as Dr. Muhammad stated in his first or second case. When we see a stent, what we can do?
Okay, yeah, we do it. Have a look at it at the bone window.
Okay.
And, okay. Yeah. All right. Okay.
You got my point here.
Yes. Yeah. Okay. So this. Yeah.
So the tip from this one before you're going to the IV contrast, Dr. Muhammad stated, when we see a double J, okay, it is better to go for a bone window, or even if you want to go for 3D, you will see if there is any stone on top of this stent or not. You got my point?
Yes.
Then we will go to this one.
Okay. This is post contrast.
Okay. Which phase?
This is arterial phase or nephrographic phase. Okay, I can see on the right side there is.
This is corticobudulary phase. Okay.
Yeah. Yes.
Okay, go ahead.
Okay, there is a rounded soft tissue lesion seen within the right kidney.
Okay.
It seems heterogeneously enhanced. It is occupying the renal. I can see within the renal medulla and renal pelvis. It has internal hypodense areas.
Okay. Nice.
There is the renal cortex seems of well enhanced, and I cannot see the fat plane seems preserved. There is no invasion into the surrounding structures. I would like to have a look at the vessels and the the renal artery, the right renal artery seems patent. Okay, and the right renal vein. Okay. It looks okay, it is patent as well.
Okay.
Can I have a look at it at the coronal as well, please?
If you okay.
Yeah. All right. Okay.
Actually, you're doing very well. Complete your description. What else by the location of this lesion you want to comment about? You commented, let's see, let me review with you. You commented on the arterial system very well. You commented on the venous system very well. What else you want to comment?
I'd like to see the upper ureter and the renal pelvis. Is it involved by this lesion or no? Here I can see that.
Which phase you want to see?
At the delayed phase.
Excellent. Okay. Let me first show you the delayed phase, then go back.
Okay. At the delayed phase, it seems pushing the calyces and the collecting system away, so it is yeah, it is not
it is displaying, right?
Displaying.
This is the accurate. Yes. Okay.
Yeah.
Go ahead.
Yeah, it's displaying the calyceal system, and but it's
so which part of the kidney you think this will be bulging from, or this will be originating from?
I think it is from the renal hilum, or the renal pelvis.
This is actually from the middle. Yes, this is from the middle calyceal system, right?
Yeah. Yes, from the renal pelvis.
Okay, we did. Okay, this is actually, I put this case for demonstration of a very good thing. This is the flow sign, or even displaying of the vessel, displaying of the pelvis on the lesion. So this lesion not coming from the pelvis, right or wrong?
Yes.
If it is coming from the pelvis, you will not see smooth outline of the renal pelvis, right?
Yes.
So this is actually exactly, this is actually from the parenchyma. If you want to make it accurate diagnosis, this is from the renal parenchyma, not from the renal system, right?
Yes.
So this is less likely to be urothelial, more likely to be renal, right?
Yeah. Yes. It's more. What did you say, doctor? It's more likely to be renal. Yeah.
Yes, not urothelial. If it is urothelial, you will not see the clear outline from the renal pelvis. Exactly. Yes.
It will be obliterated.
You will not see it is. Yes, exactly. Yes, or even infiltrated.
Yes.
Right.
Yeah.
What else? What else you want to comment on this study after we finish? We finished already the right renal system, and you did very well. You didn't miss the renal mass in the non-contrast, and this is a very good one. You did not be saturated by the double J. What else you want to comment on this system before we close the report?
If there is any other similar lesions which is not seen, and if there is any lymph nodes, surrounding lymph nodes, if there is any there is no obstructive uropathy I can see right now.
Yes.
The vessels are already patent, and no invasion into surrounding structures.
So to be surprised, you do it very well actually. to be systematized, you already take the right-sided mass lesion, describe it very well, commenting on the arterial system, venous system, then the delayed or pelvis system on the delayed image. Then you went to the perinephric fat planes, very good. Okay, then you searched for loco-regional lymph node, right?
Yes.
Then you went for distant metastasis, right?
Yeah. Yeah.
Any accidental finding. After you finished the right side, you went to the left double J, you highlighted the tool. Then the most important before finishing, if there is any residual, can we please mute? Please. If there is any residual back pressure or not, right or wrong? And if there is any super added inflammatory process on the left side.
Yeah, correct. Yes.
Okay. Yeah, actually,
Dr. Fathallah, I will unmute. Yeah, Dr. Fathallah, I will mute all and unmute yourself again.
Okay, Dr.
Dr. Fathallah, you can unmute yourself again.
Yes.
Fathallah, can you? Yes. Can you? Yes. Okay. Okay. Go ahead.
Can we shift to the next candidate, if you please, or you want to stay for another case?
I can stay. If it's
up to you. You can stay?
Yeah.
Okay, no problem. Can you check this one? Just a second. Share. You can see my screen right now?
Yes, doctor, I can.
Okay.
Okay, this is MRI coronal in a male patient.
Sure.
No, female. Female. Okay.
Okay, go ahead.
All right. Okay. Okay, I can see that both ovaries are showing peripheral multiple cystic cysts, rounded, almost of similar size, and I'm thinking it could be a case of a polycystic ovary syndrome. However, I will correlate it with the clinical history of the patient and the presentation. Looking at the uterus, okay, there is a round cystic lesion seen just on top. At the beginning, I thought it was the urinary bladder, but the urinary bladder is pushed downwards, and this is just on top of the urinary bladder. It has a, I think it is within the cervix, I would say.
What specific sequence you want to see?
Sequence, I'd like to see that the diffusion to check if it is restricted, and
let me show you this one first. That is the one I asked you about. What is this?
Okay, this is the
exactly
sagittal.
Yes. The moment you are dealing with female pelvis, it is better to have the axial and sagittal views first or sequences first. Okay.
Yes.
But I put the coronal in the start to check what you are specific looking for. Okay, go ahead.
Okay, there is a rounded hyperintense lesion seen in the anterior side of the uterus. It's yeah, the anterior myometrium is thinned out, and this lesion seems to be protruding through the anterior myometrial wall. Yeah, and there is slight thinning, perhaps erosion. I would confirm it on the axial images.
Okay.
And I'd like also to have a look at it. Rest of the uterus looks unremarkable. The cervix is unremarkable, and
what exactly you will give me on the impression for this case?
On the what, sorry, doctor?
What exactly you will give me impression for this case? The moment you see something like that, protruding as you stated exactly through the anterior myometrial wall, what is your impression?
I would ask if the patient had any previous cesarean sections. This could be a scar, and it could be an endometrial cells deposition within the scar, like an endometrioma. Else it could be if the patient.
Let me show you first the T1. This is the axial T1. Okay.
Okay. On T1 it's hypo-intense with a surrounding wall, hyper-intense irregular wall.
Then this is the post contrast.
Okay, post contrast, it's not enhancing, it only through the periphery.
This one?
Yeah. Yes.
Okay, okay. And this is the axial. You told me you want to check the anterior myometrium. Okay.
Yeah, it's very thin.
So this is the cervical canal for this one.
Yeah. I'm thinking of a rupture. Uterine, yeah.
Tell me. And what is this? If you please, what is this? What is this signal?
It's hypo or iso-intense, like a hemorrhage, bleeding.
Okay. Like, let me discuss with you. What specific question you want to ask in the clinical history of this case? This case presented by acute pelvic pain. What exactly you want to ask? Yes, about.
I would like to correlate it first with the BSCG levels of the patient.
Yes, 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 yes. Excellent. You are totally amazing. Yes.
Yeah, if it is high.
Yeah. So this patient has positive pregnancy test. What do you think?
Then it's an ectopic pregnancy within a previous scar, cesarean section scar.
Did it. Yes, yes, you did it very well. Let me discuss with you this case. So we have abnormal cystic lesion in the lower uterine segment, mainly at the anterior segment, on top of the markedly attenuated previous cesarean section scar. You asked me if she did any previous history. You don't need to ask. Just look for the anterior abdominal wall for this case, okay? At the presumed site of the scar. Before asking, we check the rectus. Yes, okay? So here, this one, this cystic lesion, it is in the lower uterine segment, not on the cervix. You told me the cervix is clear, and this is the cervix, okay? This is the anterior fornix of the vagina, and this is the posterior fornix. Then we have this one. This is the decidual reaction, and this is the remaining endometrium. So, as you told me, this case is a single diagnosis. This is ectopic pregnancy implantation on previous cesarean section scar. Do you have any fluid outside the confinement of the uterus?
No.
Excellent. So you don't have any specific signs of rupture at the time of the scan. Okay.
Yes.
You got my point?
Yes. Yes.
You describe it very well. Excellent. And this is the gestational sac, by the way, and it will not enhance. The thing will enhance this one. This is the decidual reaction surrounding this one, and this is characteristic for the early pregnancy. You can see here, this one.
Yeah. Yes. Yes. Yes.
This is the decidual. Yeah. So this is not cervical because you can see the cervical canal, and this is not incomplete abortion because already you don't see the content inside the canal or expansion of the canal. So this is specific for the cesarean section ectopic implantation. Okay.
Yes.
Thank you.
Thank you very much.
Yeah, excellent thing. Okay. Let me try to take the other candidate and share another case. First,
candidate number 9.
What we have.
Are you present?
I am present. Yes, thank you.
You are here?
Yes, I am here.
Yeah.
Okay. Actually, I am not here by this internet.
Okay.
Okay. Can you scroll this case?
No, I can't because I don't know. Please, if you can.
I can scroll for you. Okay.
Thank you.
Okay. This patient is a male patient. He sustained trauma to the left hip. Okay. Then they did X-ray for him, and after the X-ray, they did straightforward MRI for this case. Okay.
Okay.
Can you comment on this one?
Yes, it's pelvic MRI.
Okay.
In T2 with the fat separation.
Nice.
Shows replacement.
I am sorry to interrupt you, candidate number 9 and Dr. Fathallah. I will mute all the candidates, and please, candidate number 9 and Dr. Fathallah, unmute yourself again. Okay?
Okay.
Okay, thank you.
Okay, unmute yourself, please.
I did already unmute. You can hear me, Dr. Muhammad?
Yes. Candidate number 9, can you please unmute yourself?
Yes, I am mute. Yes, there is replacement of the signal of the femoral. Femoral marrow, bone marrow.
Okay.
With edema, with hyper signal and edema of the surrounding the lesion. It may be fracture of the
left femoral shaft.
It may be fracture of the hip of the femur bone.
Right. Why they specifically requested for MRI for this case?
So that sure they think about secondary fracture, upper malignant process. He searched
is that pathological fracture,
but if there is a malignant bone process who caused this fracture, not fracture.
What do you think? What do you think? This is simple fracture or pathological fracture?
I thought that it's a pathological fracture because there is process.
What do you think?
There is mass lesion. There is mass replacement of the bone marrow, normal bone marrow, by hippointense.
Okay.
T2 lesion. I like to see after contrast.
You can see this is the after contrast.
Okay. It is very destructive of cortical and it take enhancement heterogeneously. It may be osteosarcoma or no.
Think again. What is this?
There is lymph nodes.
Okay, nice.
What
do you think about this one?
Lymph node in lymph node. It's lymph node.
Right. Can I show you something?
Yes.
Okay. This is the T2, the lesion.
Okay.
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 What do you think?
T2. T2, it's very low. You like to, oh, okay. I see in bladder some polypoid posterior wall.
You're talking about this one?
Yes.
Okay. What else? What do you think about this prostate?
Yes, too. It's very suspicious. It can be metastasis bone lesion.
Okay.
Yeah, this lesion are central lesion, very hypointense, with now not marked margin. It may be pyelitis 5 or 4.
Okay. This is the peripheral zone. Okay.
This is the peripheral zone. Yes.
Is that excellent? And this is the T2. What is our message in this case? Don't be saturated by the primary lesion, right?
Okay, for research about the primary lesion of which is the prostate process.
Yes. You told me there is lymph node. This one?
Pelvic,
okay.
Yes.
Yes, and
On
this
the
one?
prostate, yes, and the prostate invade the bladder.
Invaded, yes. And this is the remaining segment of the peripheral zone that contain the normal bright T2 signal, and the remaining peripheral zone are infiltrated. I want to share with you this one. You can comment.
Okay, it's a CT scan, bony window. Showing pelvic bony structures. There is lesion, destructive osteolytic lesion of the
This
upper
is the lytic lesion of the left femur. Okay.
Of the left femur, yes. Now we will search if there is other lesion. There is of the puboischiatic.
Yes, inferior.
Yes.
Okay. So where is the primary now?
Okay.
You are right, totally. Where is the primary? It was in the prostate.
Yes. There is a huge prostate with
Look for the lymph node.
Lymph nodes, yes, iliac, internal iliac lymph nodes.
And obturator.
Obturator, yes.
Yes, and these are loco-regional for the prostate.
Okay, loco-regional.
For the prostate, yes.
Loco-regional, yes. There is likely simple cysts in. There is a mass in thyroid with calcification.
Okay.
There is humeral. There is humeral other bony lesion in the humerus.
Okay. So let me summarize this case for you. Okay. The moment you see, you stated very well, there is an infiltrative pathological marrow process in the proximal left femoral shaft, but with expansion and pathological process. Normally, at the simple fractures, you will not see the expansion, but you already minimize the image. Then look for the entire pelvic girdle. You will see multiple infiltrative bone marrow process. So don't be saturated one more time by the primary pathological process. Look for the remaining pelvic bone. Then after that, look for the T2. Already this is male patient, so the primary impression will be the prostate. So look immediately for the prostate. Either it is in the field or even out of field. So if you are lucky and you see it in the field, look for immediately the peripheral zones and the transitional zones. Then look for the lymph node. If you saw it like this one, internal iliac and obturator lymph node, so you know already you are dealing with a metastatic process. Either you check for CT chest abdomen pelvis, or you stated this is infiltrative metastatic process with pathological fraction. Okay. This is not tough case, but this is actually need concentration on the bone marrow and on the periphery of the scan. Not all the scans will be for the pelvis. Suppose you have something like that, and you already suspicious there is an expansion and infiltrative pathological marrow process, look for the prostate and look for the bladder. Okay?
Okay.
Can I shift for another case?
Yes.
Thank you so much, candidate number 9. Thank you.
Thank you.
Thank you. Good
Okay,
luck.
but
Can we have candidate number 10?
Yes, hello, I'm here.
Yes, go ahead.
let me share one more. You can see my screen?
Yes, I can.
You want to scroll?
I will try, yes.
You can try. Okay. Try to scroll.
I guess it's scrolling, I think. Yes, it is.
Okay.
So I'm presented with a CT of the abdomen and pelvis. These are non-contrast axial slices.
Okay.
I'm just going to try to scroll to the last cut before giving my comments. Sorry for the lagging, it's a bit slow.
No problem.
So I've noticed a small non-obstructive calculus in the left kidney. There's also some hypodensity, which I saw in the right kidney, but I will come back to that. I think there's also maybe mild enlargement of the right kidney and also a small calculus in the right side. So there are a few tiny calculi bilaterally, but I think the main abnormality is on the right side because the kidney is looking a bit enlarged and there's perinephric fat stranding, mainly inferiorly. Going further down, so I don't think I spotted any hydronephrosis. Just trying to go on to the level of the urinary bladder.
Okay.
So there's no free fluid within the pelvis, and so this is nearly the level. Okay. So the urinary bladder is not distended, and I just want to go down to the last slice just to make sure there's no abnormality. Okay. So that was the last image.
Let me show you another one. Okay. You can scroll this one.
Okay. Yes. So these are axial slices from the same patient. This is the post-contrast images, portal venous phase.
Okay.
And I'm just going to scroll down to the level of the right kidney where I think the main abnormality was.
Excellent.
Okay. So it's going very fast. Yes. So in the right kidney, near the lower pole of the right kidney, there was a hypodense area, which looks a bit rounded. heterogeneously enhancing, and around that there's a lot of perinephric fat stranding. So I would be thinking about any infective process, but I'm looking now at the and this patient also had multiple tiny calculi, so that would also maybe favor an infective process. I would want to look at the collecting system, whether there's any evidence of pyelitis.
Let me show you the second phase of the study. Okay, go ahead. You can scroll?
I think I can, yes. Okay, so this looks like the...
Which phase in the study, this one?
I think this might be the excretory phase. No,
Nephrographic phase. We're still in the nephrographic phase. Okay?
Yes.
Go ahead.
Okay. So this is the nephrographic phase. And on this, so I'm again looking at that area of abnormality. So there's within this rounded area of abnormal soft tissue, there is hypodense central area, which appears to be maybe not enhancing, and then peripherally there's some more soft tissue component. I can't see any other lesions within the rest of the right kidney or the left kidney, and I could not see any hydronephrosis or reactive thickening in the pelvic calcification system. But because of
you want to see the delayed one? That is the delayed one. Okay, go ahead.
Sorry, is this the delayed now?
Okay. Just a second.
Okay.
I think, yes, this is the delayed. Okay, thanks a lot. Go ahead.
So on the delayed, I would want to look for any filling defects within the collecting system and the ureters.
Okay.
So I'm just going to go on down. So far, I've not seen any filling defects or any urothelial thickening.
Nice. Okay.
The ureters are not distended. So going on further down to the level of the bladder. Okay. So even the urinary bladder does not show any abnormal filling defects. So I would ask for the patient's history, as I'm suspecting that this is a case of pyelonephritis, with maybe an evolving...
What is this? As Dr. Muhammad put an excellent case in the first part of this session. What is this?
Yes, he said it could be like the evolving stage of an abscess, so lobar nephronia.
Excellent. Yes, yes. Actually, he had my same mindset. He put an excellent demonstration, but it was here, on this area.
Yes.
So the moment you see infectious process like this one, as Dr. Muhammad stated, and you see a focal area of hypo-enhancement that persistent here, and you didn't have the courage to see it is cystic and this is abscess. So this is the stage of the lobar nephronia. You still with me?
Yes, yes.
Yes. So this is actually a case of pyelonephritis with lobar nephronia and the extension of the inflammatory process into the perinephric fat planes, and also involvement of the colon, ascending colon.
Right.
Here.
Okay, yes.
Okay. Can I stop?
You have a lot of teaching points. Thank you so much. And I think all of the candidates are enjoying. And alhamdulillah, we are recording this session. Alhamdulillah.
Alhamdulillah. Let me, you still with me, or you want to have this case?
I'm here.
Okay.
Yes.
Let me scroll this one.
Okay.
Okay. This patient have, just a second, this patient, I will give you the clinical information. This patient have pelvic pain. Okay, he came to the ER multiple visits with this pelvic pain. They give him anti-inflammatory, then discharge him without imaging. Okay, let me scroll for you.
So these are the axial slices from a non-contrast CT of the abdomen and pelvis.
Okay.
So the patient has presented with pelvic pain, so I will go down completely before giving comments.
Okay.
I noticed that there was some, okay, so there's an ectopic left kidney, which can be seen in the pelvis. I had also spotted some fat stranding somewhere in the middle. Yes, so in this region, there is thickening of the bowel as well as fat stranding. I'm not sure
which let me interrupt you for a second for our colleagues. Which part of the bowel?
I suspect this could be the sigmoid colon, probably, but I'm not sure.
Excellent. Okay.
Okay.
So this is from here, descending, then sigmoid, then the rectum and the anal canal. Okay. So go ahead. You are doing very, very good in capturing the finding. Go ahead. What you are suspecting?
Okay, so I'm suspecting sigmoid diverticulitis in this patient. So there are multiple diverticula which can be seen and circumferential thickening of the sigmoid colon with pericolic fat stranding. So now I just want to, so there's hydronephrosis which can be seen in the ectopic left kidney, and I think the inflamed part of the bowel is very closely contacting the left pelvic calyceal system.
Marvelous. So what happened?
So I think it's causing reactive urothelial thickening within the ectopic left kidney.
Yeah. Excellent. Good. Go ahead. You pick it very good. So
I would
what you want to complete or to confirm your scan?
I will want to look at the post-contrast sequences. I just want to rule out if there's any communication between the yes, okay, so this is the post-contrast sequence, which is confirming the findings of diverticulitis.
Okay.
And then coming down to, yes, so there is, I suspect that there could be maybe a fistulous communication between the, or at least there's very significant inflammatory thickening of the left pelvic calyceal system.
Let me ask you a straightforward question. Okay. If we are suspecting fistulous communication between this diverticulum and the renal pelvis, what specific phase we want to see?
The excretory phase.
Nice.
Okay, so this is the excretory phase, showing excretion of contrast into the dilated left pelvic calyceal system.
Okay.
The contrast can be seen reaching the urinary bladder, and I want to see if any of the contrast is going into the colon, which I cannot see. So I can't
there is no communication.
Yes. So
your final, in conclusion for this one?
So in conclusion, this is a case of acute diverticulitis causing inflammatory, causing left-sided pyelitis, should I say?
Excellent. Yes, I want to specifically to hear that term, pyelitis. So it is diverticulitis in the sigmoid colon, implicated by left renal pyelitis. Dr. Muhammad told us in the first session we should notice the ureterocele enhancement, and you get it very good from the non-contrast. If we see in the non-contrast here, see that one. See, you told me there is a thickening. You pick it very good from the non-contrast. So when we shift it to the contrast scan, it is very easy for you to detect the abnormality. Actually, you did it very, very, very amazing and very well. Thank you for this description. That was a case of complicated sigmoid diverticulitis with secondary pyelitis in the ectopic left kidney. Okay? See my screen?
We can see your screen, Dr. Fathallah, but I don't know candidate number 12. Are you still here? Dr. Fathallah, can you hear me?
Yes, I can hear you clearly.
Okay, okay. Can you please review the findings and give me the final diagnosis? Yeah.
Okay, for this one, we have a female patient, as she stated already, presented with acute pelvic pain. We have a hugely enlarged right ovarian tissue with a lot of heterogeneous signal, mainly at the periphery, and small still follicles here. And we can clearly see the left ovary and uterus. Yes, I can hear you, but try to review my description for this case because we are running of time. So what I'm stating here, as you said already, there is acute right ovarian torsion for this one.
Yes.
I put the case for this sign specifically. This one is the twisted pedicle sign. As you can see here, this one is the lobulated right ovarian vessels while she is twisted. So this one is the 100% sign for the ovarian torsion for this one. And the second thing is the abnormal location of the right ovary inside the mid-pelvis with the enlargement and the displacement of the uterus. While we are seeing here the coronal, see, you can see here the pedicle sign or the twisted pedicle sign very smoothly here, this one. So this one, there is no need for give a contrast for this case, because already if we give contrast, we still will have some enhancement of the ovarian tissue. This is unlike the testicular infarction. The ovary has a dual blood supply coming from the ovarian vessel and coming from the uterine vessel as well. So we don't judge the enhancement for the diagnosis of torsion. We just have a straightforward, the abnormal location, the enlargement of the ovary, and this one, the pedicle or the twist pedicle sign. Okay, and this was a case of top emergency in the female pelvic system for the ovarian torsion. I think we finish for this session, but I am not happy at all by the connection.
No. Your cases are very, very, very amazing. Really, I would like to thank you. Your description is fantastic. Your cases are too much.
If you imagine
variable.
Dr. Muhammad,
we faced some.
We still have at least 7 cases, but already the connection.
For me also, I have at least around 10 cases. So I think we need to conduct another session. Genitourinary, maybe after 1 week or 2 weeks, we will decide later on. But I think your cases are so amazing. Going up to down kidneys.
To the vein thrombosis, it was not lymphoma or.
No, it was not lymphoma. As while we are discussing this case, I told our candidate, if this one is a malignant thrombus, we have a rule, it will enhance, and the lumen will enhance of this vein. You got my point? So this one, you should carefully delineate the thrombus itself. If it is enhancing, 100% I will go for malignancy first. But if it does not enhancing, I will come back again from this one, then I will check. This could be isolated left renal vein thrombosis. So I will check for the diabetic state of this patient, hypercoagulable state of this patient. Actually, this patient, I still remember this one, she was antiphospholipid antibody syndrome. That was already stated in her clinical text. So the moment they give this one, and with still preservation of this beautiful cortical rim sign, if I have a malignancy, it will distort everything. It will not preserve the cortical outline. It will be exophytic, especially it is large mass. But I still here have some enhancement of the cortex. You got my point? So I get back one more time for this one to be just isolated left renal vein thrombosis. Then we check this patient with the Doppler to find it non-vascular even in the Doppler. So we give this one the isolated left renal vein thrombosis with secondary ischemic changes of the left kidney. Okay. You still here?
Yes, I think it's very clear now. Is there